have that first meeting with the patient, and there is the patient learning that they have advanced disease. And then there are those evolving conversations of not only advanced but progressive. And I think the one hope that we have to offer, that it's 2024, almost 25, and while we would prefer that we were meeting them at our local community event, we're meeting them here, and at least we're meeting them at this point in time. So what a time to be alive and be able to offer treatment options as a GU oncologist to our patients, because it really is, it comes down to there you are in the exam room, eye to eye with the patient, with their loved ones, and making decisions with them. Yeah. And so that'll be a good segue. Tell me just a little bit about how there's the logistics behind the scenes. I guess I would call that administrative, where you see the patient, you and your colleagues in a multidisciplinary setting agree, this is an excellent candidate for radioligand therapy. And then to me, it's like, then I push it to the black hole and like just hope and pray. But there's a lot of logistics behind the scenes that goes into it. And what have you observed, or what barriers, or how have you been able to address when it doesn't go as planned, maybe?
Yeah.
You want to?
Well, I'm sorry. I want to mention about one thing is that the travel distance is certainly one barrier.
Right.
A thing we use quite often is telehealth in our institutions, and I think that certainly can relieve and reduce some of the clinic visits. No doubt, I think space assessment will be in person. It is how we actually can assess the patient's functional status. But sometimes in reality is that there will be too many clinic visits for the patients. So we do sometimes consider assess the patients with telehealth, and it certainly help with the access to care.
It really does. So you brought up such an important point about access and ensuring equitable access to care, and the tools that we have in our tool belt, which includes the telehealth piece of it, because I think that your team did that a lot with some of the distant patients, and that was actually greatly appreciated and copied as well.
I will say we do a fair amount of telehealth, but we also work to try to get local lab work. And so we were very fortunate that we were able to get a Pluvicto navigator or a radioligand navigator, which is absolutely essential to our process. And so I think that, as new centers open up, I have found that a point person that's really micromanaging all of the labs, all of the patients that are in the hospital for one reason or another, figuring out, are they going to make their appointment? Do we need to return that dose? Should we stick another patient in that slot? It's been, at least for now, patients are very advanced disease. They are hospitalized for one reason or another, not infrequently. And so hopefully, if radioligand therapy moves up earlier, there may be less, or I'll say there may be more predictability in who's able to make it to therapy, and hopefully less cytopenias. But as of now, we definitely are blessed to have a great navigator to help orchestrate all of it and communicate with Nuke Med and the techs and our nurses and the med oncs. So it's very, again, multidisciplinary.
It is. A lot of communication, a lot of collaboration. And I think that you brought up the important point of having the clinical navigator who can coordinate that, so that as the clinician, you're able to make decisions with your colleagues. And so you have your clinical navigator on that piece. And I guess my observation is it helps to have kind of also maybe an administrator, navigator for lack of better terms, but to have a process. And I guess in essence, we follow the process that we do with any type of therapy, with the authorization piece and then just the assessment with the patient's actual plan and their impact. But there's a lot of logistics that go on behind the scenes. I know patients often have concerns about the economic impact, which really all of our therapies have a significant economic impact. And we talk about financial toxicity as well. And how has your team navigated that?
I think that with any patient with cancer, we do have financial advisors available, and we very readily refer them. We have had patients who find travel to be a burden, or overnight hotels in our city are not cheap, and so that can be a barrier to some patients getting it. Insurance co-pays, of course, all of these things, and fortunately for prostate cancer patients, prognosis is getting better and better, but that also means years and years of co-pays and financial toxicity. So it's definitely relevant and part of the discussion. Yes. And you're right, patients are thinking about not only their wallet, but just the national healthcare deficits going on, and it really is part of the conversation in their decision making, which is something we all should be thinking about too as we're selecting therapies. So.
Exactly. So I think we've really talked about a lot in radioligand therapy. There's the clinical piece, the logistics of getting the data that you need, the process that I think has really been nicely displayed at Vanderbilt on having the team and how you collaborate with your nuclear medicine colleagues, how you collaborate with your local colleagues for patients who travel. I really appreciate the role of telehealth with the local labs that you brought up, because having an advanced cancer, it's like getting a part-time job, if not a full-time job, for both the patient and their loved ones. And just the role that we have so many new and different treatment options to offer patients because they live a long time, which is great. What parting comments do you have?
No, I think this has been a great discussion, and I hope that we're back again next year and we're talking about expanded access, maybe pre-taxane use, kind of new radioligand therapies. I think it's a very exciting area.
It is, yes.
Yeah. And after the PSMA4 and the SPLASH data, I think I'm looking forward to move the lutetium in the frontal line setting. Yes. And let's see what is happening in the next few months, hopefully.
Absolutely, yes.
And then I'll echo that I'm excited for it to move earlier in treatment. I do think as it moves earlier in treatment, we need to really learn from our experience with vision and then the real world criteria for treating patients, and make sure that when we're selecting patients earlier in disease, we're being thoughtful about potential toxicities and really rigorous patient selection for earlier treatment to make sure that we're giving them the full benefit.
Absolutely. And so what a great discussion. And I appreciate how each of you have contributed to the care of our mutual and just your patients. And we look forward to, as data is published, and I think we're all going to sum it up, we all are excited for radioligand therapy to move earlier in therapy. And we look forward to next year having our next conversation about earlier disease. And thanks for joining us today and taking the time to collaborate.